Right. Welcome, ladies and gentlemen, to the first of the afternoon session, which is a lower urinary tract reconstruction for malignant and benign disease. I know it's initially titled a point-counterpoint session, but actually it's going to be more of a session of advantages and disadvantages of the techniques, and then we're going to give you a case or two at the end to allow you for the question and answer. This session is actually being filmed and audio recorded, so with questions at the end, if we can actually use the microphones that are actually provided. We've got four eminent speakers whom Margaret will introduce you to in a second. But first of all, I'd like to introduce you to Margaret Fish, who is my co-chair. She is professor and head of the University Medical Center in Hamburg and has a major interest in reconstruction in benign and malignant disease, and with a particular reference to pediatric reconstructive surgery. So over to Margaret.
So thank you very much for this nice introduction. It's a pleasure to be here. And as you mentioned, I have an interest in reconstructive urology, also especially in urinary diversion, because I trained in Mainz. So I'm familiar with all the techniques that had been developed in Mainz. And we had a close correlation and cooperation with the Mansoura group. So we together also did quite a lot of studies on urinary diversion in the past with that group. So we start with different types of urinary diversion, and we start, let's say, with the most simple ones, the ileal conduit. And I asked Ms. Charlotte Foley to give her lecture on the advantages and disadvantages, and also indications and contraindications.
Thank you. So good afternoon, everybody. So yes, I must say I was quite pleased to be appointed this particular topic, because it does feel more simple, but as I will explain to you, the patient's experience isn't always as simple as the surgeon's intraoperatively. So when you tell a patient that you need to remove their bladder, their next question is usually, but what happens to my urine? And I tend to say something like, well, we've got quite a few options to discuss, but you might end up draining your urine onto your tummy, into a bag for the rest of your life. And at that point, they look even more miserable. And it's certainly true that, at least for some bladder cancer patients, this is the most feared of the urinary diversions you might offer them. But actually, bladder cancer patients do have some choices that, as we'll hear that later on, there are a few other reconstructions that may be appropriate for them. And there are other populations of patients with benign problems, anticipating many years of life ahead of them, who may not have quite so many options. So the ileal conduit's been around just over 60 years. It's not the first time anyone tried to divert urine out of the urinary tract, and in fact that was the first attempted by Simon back in 1852, where he plumbed some ureters into the rectum with his rather soberly titled Lancet paper, in which he described his experience. The use of ileum to divert urine to the body surface was popularized by Bricker in 1950 and then modified by Wallace in 1966. And these two techniques are very much the mainstay of how we do the procedure these days. And the indications for an ileal conduit are often in patients in whom you have no other choices. And this will be for palliation, the frozen pelvis in bladder cancer, where you just want to divert urine away from a very symptomatic bladder and give the patients a degree of quality of life in their not so many years left. Or you might use it as a sort of pragmatic choice in the high-risk bladder cancer who can have a cystectomy, but you're worried about pelvic recurrence and you'd rather not be coping with a near bladder situated amongst all that recurrent disease. And then there are some situations in which, if you've got a patient with a cognitive impairment, they will probably be able to manage their stoma more than they'll be able to manage any other reconstructive, and that's certainly true for their carer as well. And finally, the renal impairment, the patient with renal impairment. This is something that is going to recur through this afternoon. The suggestion is creatinines are over 150 or 200. You really don't want to expose too much of the absorptive intestinal mucosa to urine if you can, and an ileal conduit certainly offers the least surface area a short, straight ileal conduit will minimize the amount of urinary reabsorption and the metabolic consequences thereof. And contraindications, there aren't that many, but it might be where you daren't or can't use the bowel. But of course, there are other intestinal segments that can be recruited in these instances. So this is how to do an ileal conduit, and I suspect almost everyone in this room knows how. They can be done robotically these days, intracorporally, and the procedure is very much the same. Your robotic surgeon will be able to do either anastomosis as he wishes, and the only real difference in technique is that where we might irrigate the conduit segment to remove in the unprepared bowel, to remove some of the intestinal contents, they do not do that in the middle of the operation, in the middle of the abdomen. So if you're making your conduit, you first of all wall off the rest of your abdomen with some large swabs. You select a suitable part of the terminal ileum, sparing the last 20 centimetres or so that you don't impair B12 and fat-soluble vitamin absorption. And you want to create a stoma, a conduit that's on a good pedicle and not too long, but also which can reach the body surface, which may be something worth thinking about in the very fat patient. And then it's important to close the window you formed in the mesentery once you've isolated your bowel segment. It's also very important to remember which end was most distal, because you must place this conduit in an isoperistaltic fashion. Once you've got your segment of ileum separated, then you need to get your ureters into the right place and anastomose them. So you have to take your left ureter, tunnel it under the sigmoid mesocolon. You want to make sure the root of that ureter is fairly straight. You don't want it to take any sharp right-hand turns, and it needs to be the tunnel it passes through, formed by blunt dissection, needs to be big enough that it's not going to be a source of obstruction. And then you have two choices of ureteric ileal anastomosis. The Bricker technique is to plumb them in separately, the left more proximal to the right, and that also means you've got this stump of the conduit even more proximal, and if you've stapled that, then it's generally advised that you remove those staples and hand sew it with absorbable stitches, otherwise you can get stone formation on the staple line. An alternative is the Wallace technique, and depending on how the ureters want to lie, they will either be parallel as a BAUS16 or coming in from opposite directions, which is the BAUS69. Either way, this is spatulated. You create the back plate and you sew your ileum onto it. And it's critical that the ureters are kept well covered in their intimal tissues, which brings their blood supply, because if you strip the ureter back, then it will become ischemic and it will stenose and it will leak. And you will be forever, well, you and the patient will be forever paying the consequences. And then you form a stoma, the other end of the conduit, and your stoma nurse has marked the spot appropriate to the patient's body habitus, the folds in their abdominal wall, the bits they can see and reach, and how they like to wear their trousers. And then you excise a circle of skin, a cylinder of fat down to the rectus sheath, and then make a cruciate incision in the rectus sheath, to which you anchor your stoma, and you also then fold it back to give yourself a protruding stoma so that the urine clears the body wall as it hits the stoma bag. And here we've got a nice picture with two ureteric stents. These could be feeding tubes or single J stents, and it's very clear in the literature that stents will support your ureteric anastomosis and make a big difference to the amount of leak or stenosis. So they're very important. And they're sewn in and will fall out of their own accord subsequently. And so in terms of whether you should favour a Bricker anastomosis or a Wallace, well, a number of studies have looked at this, and the tendency seems to be to favour the Wallace, but a recent meta-analysis that pulled quite a number of studies suggested that in terms of stricture, there is no reason to favour one over the other, and there's no significant difference between outcomes. There may be other reasons to favour one anastomosis over another. So the Wallace works better if you've got two similarly lengthed ureters sitting next to each other, whereas the Bricker will work better if you've got different ureteric lengths, and some obese patients, you may find that the left ureter, by the time it's come over, isn't as long as the right. And also, if you've got a situation where perhaps a patient with CIS, you're worried about recurrence at the level of the ureteric anastomosis, then you might favour a BRCA, so they won't obstruct both kidneys at once, and it might be a little easier if you find yourself coming back to remove that recurrence. Conversely, if you've got a stone former and you hope one day to take a retrograde approach up to their kidneys to clear their stones, then you're going to be in with a fighting chance of finding the ureteric orifice with a Wallace, but probably not with a BRCA. So there may be other things that influence your decisions. So obviously every operation has complications. You've sold this to your patient as a simple technique, much lower operating time, sort of get them out of hospital quickly. And these are the early complications you might mention to them. But of course, many of these patients have had a cystectomy at the same time, and they will have complications due to that as well. In terms of late complications, certainly these can occur many years down the line, and it depends how long you follow patients up for. And one paper that really tried to pin down the likelihood of the legacy you're leaving your ileal conduit patient with looked at patients who'd lived beyond 15 years and found that most of them had had some form of complication by that point. And if we look at these complications in more detail, it's quite a long list, and these are obviously these are the commonest ones. So we know that there's a high risk of pyelonephritis. Your conduit is chronically colonized with bacteria, and these will manifest themselves as febrile urine infections in 1 in 5 of your patients. We know that the metabolic consequences aren't as great as some of the other options we'll hear about today, and they can form stones. But I think the important issue and the life-threatening issue is what happens to their kidneys over the long term. And it's certainly, although this would seem to be the most favoured approach in someone with some renal impairment, they don't do too well with it either, and these people need long-term follow-up. And the predominant cause for that is some form of obstruction, be it in the conduit, at the stoma, or at the anastomosis. And this needs to be recognised and treated because they will decline their renal function. And there was one study that looked at the relative success, the renal function over the years in patients with neobladders versus chondri, and it suggested that in fact diabetics and hypertensives seem to do worse with the chondri, and maybe these people should be getting the neobladders. And so that's certainly something to discuss with your patient. Equally, there's the complications with stomas, which are multitude and many, and actually quite likely. And this stoma, of course, the patient must interact with on a daily basis. And if it's a struggle for them every day. So I looked at this and I thought, well, maybe we all work together these days. We collaborate with other specialties, and urologists don't do a lot of bowel handling, and we make even fewer stomas, and maybe the general surgeons should come along and help us. So I looked at some general surgical data. Here's stomal complications, 15 to 65%, and then here's a paper about stomal complications in general surgical patients, 13 to 65%, exactly the same. So we're doing it right, it seems to be a feature of what we're trying to achieve surgically. So which patients choose chondri and why? Well, about 33% of people will, and this will depend on your centre, but 50% or so will go for more elaborate reconstructions. Many women do, and that's because they don't like the idea of self-catheterizing, so being too continent or ongoing stress incontinence. These people tend to be older, perhaps less fit, and they like the idea that it's simple and there's less work to do subsequently. And they may also have, the older population may have less body image issues to make them resist it. So in summary, I think the advantages of a chondri are that there's less aftercare, it's a low pressure reservoir, and you can avoid some of the metabolic consequences. But against that, they do end up with a stoma. It's very obvious, they're incontinent, and there's certainly evidence that the patient with a neobladder will get out there, will have more leisure activities, will have more intimate relationships, and will have better relationships, despite being a bit incontinent, than the patient with a stoma. But I would say one thing in the defence, that the trouble is the population who have ileochondries are the population who are more likely to have complications. They're older, more comorbid, less fit, and so it might be partly due to patient factors rather than just the technique itself. Thank you.
Thank you very much. We continue immediately with the next presentation, and I ask Ms. Mary Garthwaite to give the presentation on orthotopic neobladder.
Okay, so I've got 15 minutes really to talk you through orthotopic neobladder, which I will try and do. I don't have time in this to go into the wealth of different surgical techniques, but I will cover the most commonly used. Indications, well, it's really to maintain continence and allow for more natural volitional voiding following cystectomy, be that for cancer cystectomy, malignant reasons, or for benign reasons. It requires creation of a new urinary reservoir, which we construct from intestine, and that is connected to the urethra. There are continent neobladders which connect through to the skin, but they're not orthotopic. Orthotopic implies that you are actually going to be putting this to the native urethra. Contraindications, well, some of them are have already been mentioned by Charlotte, but compromised renal function really is a definite contraindication. You need a patient with good preoperative renal function for this technique to be considered. If you've got a patient who already has a history of stress incontinence, a lady with stress incontinence, or you feel that there is a high chance of urethral incontinence or damage to the sphincter during surgery, this may not be the ideal option for them. If there's a history of significant intestinal disease, such as Crohn's disease, then it's not really going to be a feasible idea. Compliance issues really is a sort of term that covers the patient and how they are going to be able to cope with the intense rehabilitation period post-operatively, getting to learn to use their neobladder, and whether they have good cognition and dexterity and even mobility, because obviously these patients are going to still travel to the toilet and get themselves to the toilet in the long run. If the patient does have multiple comorbidities, you want to think about this a little bit more, because if in that situation, if you're wanting to keep operative time to a minimum, and that you've already got to get them through the cystectomy, then a complex reconstructive technique may not be a viable option, and something that is simpler to perform, such as a conduit, may. And of course, a positive urethral margin. And I'll talk a little bit more about this in terms of the data and how often this is performed in men and women traditionally. But if you have a positive urethral margin, then you're not going to be wanting to create a new bladder attached to a native urethra. So in terms of operative technique, then the terminal ileum is the bowel segment of choice. Small bowel is more compliant than large bowel. Many parts of the bowel have been used for orthotopic neobladders, including the stomach, including the sigmoid colon, but small bowel is more compliant. It's best at compensating for metabolic consequences. It is easier to handle in terms of the detubularization and folding, which you need to construct a low-pressure reservoir. And those principles, the detubularization and the folding to create a reservoir, are the underlying principles for orthotopic bladder reconstruction. So in terms of techniques most commonly used, I think the literature bears out that Studer-Ilio neobladder is the most commonly used, or variations thereof. That involves using around 60 centimetres of terminal ileum, which you take 20 centimetres proximal to the ILC Core Valve. You open the distal 40 centimetres of that along the antimesenteric border, which you can then stitch to create a U shape, and then fold that U to create your reservoir. And the intact proximal 20 centimetre chimney is what you use to implant your ureters into, and it's the isoperistaltic waves that prevent reflux. The other techniques that have been used and are still used today in certain centres include the Koch ileal pouch, and this was initially designed as a continent cutaneous reservoir, which used intussusception of the bowel segment to create nipple valves, both for anti-reflux to the upper tract, but also as a continent mechanism to the abdominal wall, to the catheterizable stoma. But it did evolve to an orthotopic pouch where you still keep the intussuscepted nipple valve as an anti-reflux mechanism. For this, you need two 22 centimetre roughly distal ileal segments, which you shape into a U again and fold to create a pouch. There are various configurations of that. There are things you'll read about called T pouches and I pouches. And then I thought it also worth mentioning the Hauptmann ileoneobladder, which was developed to increase nighttime capacity of the neobladders. It uses a longer length of ileum, which is shaped into a W configuration and then folded and closed, and you use a buttonhole to anastomose it to the urethra. There were many adaptations of this, and one of the most significant was an anti-reflux seromuscular tunnel for your ureters into this pouch. Initially, when it was first established, the urine was able to reflux up through. So in terms of data, I think this is where it gets interesting to do with orthotopic neobladders. In terms of the UK, I'm drawing your attention to two recent publications, both of which have shown that the current data we have available, and this is looking at both the BAUS cystectomy registry data, but also using the HES data, suggests that we have a rate of around or just under 7%, so about 1 in 15 patients having their bladder removed will end up with an orthotopic neobladder reconstruction. Interestingly, this data does pull out the fact that it is only 2.9% of these patients that are female, and historically there has been concern about orthotopic neobladder creation in women because of the risk of recurrence in the native urethra. The second study, Hounsome et al. Did look at the work across the UK cancer networks and found that there really wasn't that much variation. 14 out of the 17 cancer networks at that time, between 2004 and 2011, were performing these procedures. They again showed that it was lower in females, but also mentioned that the older the patient and more deprived the patient, as well as the disease status, did have a bearing on whether orthotopic neobladder reconstruction was utilised. And some of these themes are borne out in the American data. In terms of, Gore et al.'s paper showed that in terms of the SEER Medicare cases that they looked at between 1992 and 2000, although they have a higher rate of orthotopic reconstruction, around 20%, there were various factors that influenced that decision. Among them were comorbidities and age, which I think we all take for granted as sort of reasonable factors to consider. Women really didn't get orthotopic reconstructions, again, just like the UK data, but there were also differences in terms of race, and that tended to have a basis in the fact that in Afro-Caribbean population, you can often find more advanced aggressive disease. But they also showed that in the lower socioeconomic groups, this was not really taken up, and that's something that came out in the UK data. They cited various clinical factors, disease status, but also factors such as the centre in which you had your surgery, so the surgical skills mix, and they pulled out the fact that in specialist centres you would have rates of up to 60% of orthotopic neobladder construction. Despite the advantageous outcomes for the patient that they listed, they agreed that there was no discernible increase in its use over that time period. European data tends to show rates of orthotopic neobladder reconstruction varying between 15 to 60%, and again it depends on the centres they look at. So the most specialised centres doing a high volume of these cases tend to be giving the higher rates of orthotopic reconstruction. But again, it is less common in females, less common in the over 75s and in advanced disease. So it's interesting that although as this technique was developed, it was felt that it should really be considered as a gold standard, something to really consider in your patients if they were fit enough, that the trends in adopting this haven't really followed through on that, and it might be that actually we're getting a natural balance which is lower than the predicted take-up. We're entering a new era robotically, and there are various centres who have started looking at intracorporeal orthotopic neobladder reconstruction. And the group in the States, published in the European Urology earlier this year in February, have reported on their first 28 patients, all of which were male patients. They only had 9-month data for this patient group, but they compared it with, I think it was 79 of their previous open orthotopic neobladder reconstructions. And they felt that even though the data was limited, that they were getting similar bladder cancer specific and generic health related quality of life scores, but there was a trend already for worse urinary incontinence and worse continence outcomes. I know that there are a couple of centres in the UK that are looking to form trials to look at robotic intracorporeal orthotopic neobladder reconstruction. So I think this is a space to watch closely to see where we get to. So just to summarise really, pros and cons. Well, there are a lot of pros, particularly if your patient is horrified by the idea of having to have a stoma. And wants a more cosmetic procedure which allows them to have control of their continence in the long term, which is functionally less constraining for them. They can still go swimming easily. In fact, we had one gentleman in Middlesbrough who was concerned about his livelihood. He was a deep sea diver. And in terms of diving, there is a potential issue with having a stoma. There is literature to suggest that there are improved quality of life outcomes, but I would suggest that if you counsel your patients well, that whatever they end up choosing, they will probably be satisfied with. So if you counsel them about the options that are appropriate for them as an individual, they make a reasoned decision, then they are likely to be happy with whatever they choose, be it an orthotopic reconstruction or an ileal chondry. Currently, there is no difference in morbidity or mortality data compared with ileal chondry. In terms of the cons, well, it is a longer operative time and it is increased technical difficulty of the surgery, but from a patient perspective, it is the prolonged rehabilitation phase afterwards which will give them the greatest challenge. These patients do need to be followed up in the long term, and you do need to think very carefully about your choice of patients to put through this procedure. I think that there is emerging less caution with female patients than there used to be traditionally, so I would anticipate we may see an increase in the number of women that are being offered this, and it might be that in the new era of robotic surgery and robotic intracorporeal orthotopic neobladders that more patients do take up the option. I think it will be interesting to watch this space and see. Thank you.
Thank you very much, and we continue with the next technique, which is a pouch with a continent stoma, presented by Mr. Mo Belal.
Hi, good afternoon, ladies and gentlemen. So I've got the talk on continent diversion. We'll talk a bit about the history in terms of also what types of continent diversions are available, when to use it, when not to use it. I'll give an example of an operative technique, since there's so many around, and then we'll look at some outcome data and try and summarize. The concept of a continent diversion has been around almost since the early 20th century, and Macas originally created a pouch, but unfortunately he did not have a decent continent mechanism with that. And then Gilchrist in 1950 had used a bit of ILC Core and created a pouch which appeared to work, but unfortunately that was not reproducible with other people. We've already mentioned the cock pouch, and then really it took off in the sort of late 70s and early 80s with the Lumiana pouch, then the man's pouch, which is probably the most commonly used pouch in the 80s, and then the Indiana pouch. I think in terms of principles, there are three parts to it. Firstly, you need a low pressure reservoir, and that's very important. You need a continent mechanism, and then you need a drainage method. And obviously, you need to have an understanding how you're going to reimplant the ureter, whether this is going to be in a refluxing fashion or a non-refluxing fashion. And as comparison, if you look at an islet conduit, obviously that is the conduit. If you look at an orthotopic neobladder, the reservoir, if it is a Studer neobladder, tends to be the ileum, and they use the continent mechanism of the urethral rhabdosphincter, and the actual conduit itself is the urethra. Now, with continent diversion, one of the most commonly used ones, you tend to use the ILC Core segment of the bowel. You try and use the ILC Core valve itself and use the conduit as the ileum. Dan Wood will no doubt talk about the ureterosig, and again, that's using the anal sphincter as the continent mechanism, and the anal rectal as a conduit per se. So what can you use? In fact, you can use so many different things, and hence why you have so many different surgical techniques on essentially on the same principles. You can use native bladder, you can use any part of the gastrointestinal tract, stomach, jejunum, ileum, cecum, colon, rectum. In terms of the continent mechanism, you can use a continent mechanism which is already in place, whether that is the native urethral sphincter or anal sphincter, or you can create, using the Mitrofanoff principle, or using an anticipated valve principle, a continent mechanism. And the types of conduit you can use can vary too. Not included on there includes the fallopian tube, which has been used before. So in terms of how to classify continent diversions, I think you can classify according to the type of bowel used. And obviously the Indiana and the man's pouch, the ILC Core segment is used. The Florida and Miami pouch, it tends to be colonic. And the man's 3 pouch is where you use a transverse colon, and that tends to be in irradiated patients. And the idle pouch, we've mentioned the cock pouch, there's a T pouch, there's a Monsura pouch. We could probably make up a pouch here today, and we could call it the BAUS pouch with a different configuration. But the principles nevertheless stay the same. In terms of when to use it, obviously if a patient wants to be continent, and in particular in the UK, I would say the orthotopic bladder is actually what most people would use. It's times when it's not agreeable. For example, there's bladder cancer in the urethra, or CIS in the prostate, or intractable urethral strictures. And also mentioned before, female patients. All the neobladders I've done, most of the female patients have had to self-catheterize, and that can be rather cumbersome. In terms of contraindications, not surprisingly, renal impairment, a creatinine of 150 to 200 is not ideal. Hepatic impairment, and that's with ammonia, and to deal with the metabolic acidosis that can occur with these sort of surgical techniques. Bowel dysfunction, predominantly in terms of Crohn's disease, ulcerative colitis, would preclude you from considering this. If they have a significant psychiatric disorder, then obviously you would try and avoid that. Age, I've given an arbitrary cutoff of 75. I'm sure we can argue about that. In terms of complications, not too dissimilar. Infection, stenosis at the cutaneous level or at the ureteric ileal anastomosis. One of the biggest problems of these pouches tends to be stone formation, and that can be a significant problem. Rupture can occur any time from the time of the surgery. I've briefly mentioned the metabolic abnormalities. In terms of malignancy, I'd say that there is a finite amount of malignancy, but not more so, probably less so than the ureterosig. So just as an example of a surgical technique, I've decided to choose the Indiana pouch just to run through the technique of how to do this. Firstly, you have to harvest 25 to 30 centimeters of cecum with 10 centimeters of ileum over the terminal ileum. Then you create a cystostomy, pass the catheter through into the ILC Core Valve. Then you need to taper the ileal segment, which can be done in a multiple of different ways, using analysis, excising it, and suturing it in place. Then there's additional plication sutures required to allow the nipple to go in and strengthen that mechanism of the ILC Core Valve. The next part is to bend the cecum into a U shape and then incise that and suture that accordingly to detubulize the cecum. It's important to do that because the colonic pressures tend to be high. Then you close up the holes and then you reimplant the ureters. And then subsequently you would then have to anastomose the segment up to the skin, ideally the umbilicus or to the right-hand iliac fossa. How about the functional outcomes? So let's just talk about continence. In terms of continence, there's a big variation in terms of success. And the largest series of 800 patients with MANS 1 pouch suggested a very high continence rate of 93%. What they did find was that if you use the appendix as a stoma, you tend to have a higher continence rate than if you did it intercepted nipple. In terms of quality of life, people have compared continent diversion pouches with orthotopic, and most people have found both those to be equally acceptable, though they did notice that the orthotopic patients had a greater degree of leakage. But when you look at it in terms of a systematic review of all patients with a continent diversion, with an orthotopic bladder or a conduit, really there isn't that much significant difference in quality of life. So how about renal function? Well, there was a randomized controlled trial looking at the 3 different types of conduit and continent diversion, and at a mean follow-up of 10 years, there's no significant statistical difference in the GFR. How about complications? This is a paper published last year in the BJUI. They routinely offer all 3 aspects of the surgical technique, predominantly with the conduit. A quarter of those patients received a continent cutaneous diversion and 25% received an orthotopic bladder. They had 2 forms of one a modified Indiana pouch and another one using the appendix stoma as well. And they looked at this sort of medium follow-up, almost 3 years, and they found no differences. So a summary slide of all the sort of common use pouches, whether it's the Indiana pouch, Florida pouch, Mansoura pouch, or MANS. And it's fair to say that in terms of continence rates are pretty high. In terms of complication rate, complications are limited predominantly to the anastomosis at the ureter, also at the stoma and the nipple. The pouch calculi have varied from 5 to 10%, but certainly in my practice, that is a big long-term problem that I do have. I do take over a lot of pediatric patients from Birmingham Children's Hospital, and forever I have to deal with a significant amount of bladder stones as that. So in terms of conclusions, it's a technique which is perhaps least thought about, but something we should be considering more, especially in the female patients who don't want a conduit. In terms of complications and outcomes, it's very comparable. And I think whenever you've got a patient who would be suited for an orthotopic neobladder and is a female or you're concerned, then it's worthwhile considering this as a thing. Thank you very much.
So thank you very much. The last presentation will be on the oldest technique of urinary diversion, ureterosigmoidostomy, presented by Mr. Dan Wood.
Thank you. Let's see if I can get this to work. Okay. Excellent. Section, BAUS, Chairman, thank you very much for asking me to talk this afternoon. I seem to have, in the car between London and here, I seem to have developed a slightly husky tone. I'm not trying to be like Tony Monday, I'm terribly sorry. Okay, so I'm going to try and talk to you about dual stream diversions, and I've titled the talk the Minds 2 procedure because that's really the mainstay of these diversions that are used in practice today, if at all. Although it's rarely used, and for many reasons, it's fallen largely out of favour. There are some examples there of the techniques that we have available, and we've heard obviously about those as part of the presentation so far this afternoon. This is a young man that I met in Southeast Asia when I was seeing some patients over there as part of a charity thing. And he was born with born with a neuropathic bladder, and his mum was a bit upset that he was incontinent. He'd reached the age of 16. And they'd done a really very old-fashioned technique where they'd created a direct fistula between the back wall of the bladder and the anterior wall of the rectum. And really that's kind of what we're talking about is creating that dual urinary stream. But this guy hadn't coped with it very well, obviously, because he had a very high-pressure system. So we've seen a progression over the years in terms of how this type of technique has developed. We've already heard in the first talk a mention of Simon's original ureterosigmoidostomy. We understand that over time that failed or was not successful because of the high pressure nature of it. And so we've seen a progression of different techniques and refinements through time to what we currently have. Mo alluded to this, and the substrates that we have available for urinary diversion and how we might approach it through different techniques and different ways of creating our reservoir, our conduit, and our continence mechanisms, all of which are important. And he's also alluded to this, that in this particular circumstance, it's the rectum that's our reservoir, it's the anus that's our conduit to the outside world, and we're reliant totally on the anal sphincter. And that helps us when we start to think about how we're going to select patients that might be suitable for this type of diversion. But then there are those that are not suitable. And if you have already pathological or dilated ureters, it's going to be very difficult to employ this as the technique. The same is true with radiotherapy, and we do not want to disadvantage patients with chronic renal failure because of this. And there are a couple of different reasons why that's particularly important with ureterosigmoidostomy. It's not suitable for those with any form of anal incontinence, whether that's related to neuropathy or otherwise, because a dual stream effluent is extremely pungent and unpleasant, and so being incontinent with that is just not manageable. And if they have any kind of bowel abnormality or abnormal colonoscopy, that they would be excluded. And so just a couple of examples of how things have evolved. The original ureterosigmoidostomy, that can be directly plumbing the ureters into the cecum, turning the trigone patch around, dismembering the rectum and replumbing it to create the so-called Gersony. But they failed because of, as I mentioned, the high-pressure nature of it and the continued preponderance to incontinence or anal incontinence as a result. And so we understand now with time that, that increasing the volume reduces the pressure. It's just Laplace's law. And that then allows us to store more at lower pressure and avoid the leakage that is important, that is so difficult with patients. So the Minds 2 group, Margit Fisch along with Rudi Hoffenfeller, did the original work looking at this particular form of reconstruction. So we see an increased capacity with lower pressure. Continence is therefore better, but we do understand that in these patients, acidosis or metabolic anomalies can be a big problem, hence the reference relating to renal function earlier. We understand the malignant risk, and we'll talk about the progression of that. And you can occasionally see, as with any form of reconstruction, ureteric strictures. There are various ways of assessing patients preoperatively. You can use fancy anal manometry if you wish. In those that have been done at UCH, we've used a slurry test where we've put about 200 mils of water combined with a Weetabix or porridge paste into the rectum, left it there, and if they can walk around for an hour or so with that and retain it, then they're probably going to be suitable for this type of diversion. If they can't retain it, then they're going to be incontinent and they're going to have the problems that I mentioned earlier. So you have to think about this on the basis of what I've just said in terms of patient selection, that this is a highly selected group of patients. You would not sit in a clinic, talk to them about a ureterosigmoidostomy and then do it in the same way as you would perhaps with a continent diversion or an orthotopic neobladder or an ileal conduit. These patients need to be assessed for their anal continence. So the continence data, by virtue of that, is good. They are generally speaking continents, and if they're not, it's a disaster. They really need another form of diversion. But they do have a lot of metabolic anomalies, or a greater tendency to hypochloremic metabolic acidosis, and that's because probably of the organisms that are present as a result of a Dualstream and the dwell time within the anorectum prior to emptying. So just a little bit about the technique. This is a very kind of cartoon diagram, but I'll just take you through some better pictures. You can see that the ureterosigmoid is brought down, the rectosigmoid is brought down into a U shape and then opened on the anterior border. Then the posterior part of that wall is then closed. That then allows you the back wall of your reservoir. You're then going to tunnel your ureters in. I'll just show you a better picture of that. It's very, very important. There is no debate in a ureterosigmoidostomy about tunneled or not tunneled as far as the ureter is concerned. You cannot have reflux from these reservoirs because it's piss and shit going up to the kidneys, which is not good. So you must have an anti-reflux mechanism as part of this. Then you close the front wall. You have a big size 28 catheter that goes in through the rectum, and your stents come out alongside that to maintain the anastomosis in much the same way as Charlotte talked about as part of the ileal conduit. We want those anastomoses secured and healed before we take those stents out. And there'll be a tendency throughout their post-operative period for them to want to poo that catheter out. It's a great big balloon and it doesn't sit comfortably, but it needs to stay there, ideally for about 10 days or so. Thereafter, you get a nice pouchogram with good ureteric drainage, as you can see on the historic IVU photo. There have been various other discussions relating to anti-reflux mechanisms and augmented valve bladders, putting an ileal patch on the front, but the most simple, the most straightforward, and the one that seems to be most reproducible and is used widely, particularly outside of the kind of more first world environments where you may not have access to bags and catheters quite so readily, is the MINDS 2 reconstruction. So there's, again, a nice illustration just of the operative progress. If you've not seen one, it's worth just having a quick look at. So early complications, you can lose your stent. There are the respiratory and hemodynamic complications and wound dehiscence. Many of these patients can be quite poorly. It's used a lot in malignant reconstruction and some ileus. We've already talked about the fact that they can have ureteric stenosis. They'll still get upper tract stones, and they can rupture as well if they're not emptied regularly. So it's important that the patients are well counselled and motivated. Daytime continence, as I talked about, is high, along with, well, all continence is high as a result of the pre-selection. Some patients will require oral alkalization in the form of sodium bicarbonate to maintain their acid-base balance. We've also seen, this is the worst group in terms of metabolic anomalies of all of the urinary diversions. It's important just to remember that if you're teeing patients up for this. We've seen at UCH 2 patients that have had hyperammonemia that have required us to take down and divert them as ileal conduits. Both were extraordinarily unhappy about having to have a conduit as opposed to their ureterosigmoidostomy, but metabolically and physiologically much better as a result of it. So in terms of comparisons, there's not a great deal of data that really that helps us with that, but in terms of immediate post-op complications, this paper from Spain shows that actually in the immediate period, there's not a great deal of difference between an ileal conduit and a ureterosigmoidostomy, but if you go into the mid and longer term, I learned that eventration means herniation. I had to Google it. I'm sorry if I was slightly ignorant, but there we are, that's what it means. But there is a tendency to pyelonephritis and also to metabolic acidosis, all of which we've discussed. So they're not unexpected changes in terms of the difference between an ileal conduit and a ureterosigmoidostomy. Really the big and most important thing that we need to manage and think about is the tendency towards malignancy. And it's because of the four things that you have together. You have urine, you have feces, you have urinary mucosa, and you have bowel mucosa, all in the same environment. And when you have all of those four things, that gives you a predictable tendency towards malignancy. If you remove any one of those things, the malignant risk falls off dramatically. And here you see an example of a benign polyp at the ureteric junction with the bowel. It always happens at that junction. But if you see a benign polyp, it's not you can't just excise that and leave it or observe it. There is a predictable progression to a malignancy, and so you have to remove the anastomosis, take down, and replumb it if that is seen. We know that there's about a 25 to 30% risk at 20 years or so, and when they arrive, they are predictably aggressive and have a high mortality associated with them. So our patients would be followed up with a flexible sigmoidoscopy from about 10 years or so and looked after in the vein that I've talked about. Patients like it. If they have it and it works for them, they like it, and so they'll want to stick with it. So when you ask the question who would voluntarily change their reconstruction from uretero-sig, the answer is almost no one. And some of the papers have gone to help us with bearing out that data. Christopher did his own look at his own patients over time and found that those patients who he had to redivert were really very unhappy about it, didn't like it, and would like to have gone back to having uretero-sigmoidostomy despite the risks or complications that they may have had with that. Just as an addendum to this, I've just included the double-barreled wet colostomy just as an aside, because I think it's important when you're dealing with a range of malignant patients, and or a range of patients, including those who may have malignancy that needs palliation. It's just worth thinking about, and as it's a dual-stream diversion, I included it in this talk. And this is where you have the two parts of colon brought up as a double-barreled colostomy, and one tail has the ureters, or the distal tail has the ureters plumbed into it, and the proximal tail is the bowel stream that comes out into the same bag. It saves the patients from having to manage two bags. It's operatively relatively straightforward to do. If you look at the data surrounding it, the survival data and the ongoing data of it is relatively poor, but the substrate, the patients that are actually undergoing this type of procedure, it's often used for palliation, and therefore you're dealing with a skewed population by definition. So 30-day morbidity and mortality is very, very high, but then that relates to some of the other difficulties that these patients have. It's a selection problem, I think. So in summary, when you come to talk about uretero-sigmoidostomy or the MINDS 2 reconstruction, it is a good operation. It has fallen out of favour because lots of people don't like the dual stream element, but it does have the advantages of avoiding a bag, avoiding a catheter, and so in some environments and for some patients, it's a very applicable reconstruction. It's not right for all. You absolutely must have a continent anal sphincter, and you need to have somebody who will watch you from the point of view of your metabolic status and your malignant risk as part of long-term follow-up. Thank you very much.
Right, thank you to the speakers so far. I'd like to invite all the speakers to come up to the table. We just need to bring some chairs up as well. Professor Fish is then going to introduce a case or two, depending on time, and we're also going to try and get some audience involvement as well. Could I also have a roving microphone up the front as well, please?
It's not working. Connected up, but it's not opening. Yes. Oh, you put it down there.
I had it all stitched together, but then he came out of it. Let's see. Not yet. Are we there yet? No.
Okay, Charlotte, while we're waiting for that first slide to come up, I'm just going to play slightly devil's advocate. Obviously, the complication rate with the ileal conduit is shown to be pretty bad there when you compare it with the figures for continent diversion and the other forms of reconstruction. Is the ileal conduit dead, Charlotte?
I don't particularly want to defend it. I don't feel I'm here to sort of defend the ileal conduit. I think it really depends on the individual, and there are so many instances where you're going to need to perform a urinary diversion that you need to lay out the options, and the patient, above all, the patient may tell you what they want once you've informed them. But I think it's often a registrar procedure. Maybe we should take it back from the registrars, but I think it's under-recognised as to some of the consequences. So if we've done nothing else today, it's better patient counselling. Okay. Is it dead? Well, they may not have a choice.
Okay, Margaret's now going to introduce a case for the panel to discuss.
It's a pediatric case, but we can use it at least to discuss the most important parts and issues of urinary diversion. So this is a 12-year-old girl. She presented at our institution. She had a bladder exstrophy and had a bladder plate resection and a mitral operation. That means an anastomosis of the complete trigon to the rectus sigmoid. And she presented with a recurrent febrile urinary tract infection. She is living in Russia, and she was coming for an alternative or an option. So would you like to have more information on these, on the kit, Dan?
Yeah, you say she's got...
Microphone, please.
Thank you. You say she's got recurrent pyelonephritis. Does she have any other problems? Is she continent at the moment?
No, she's completely continent. Any other issues concerning the upper tract? Any one of the others? We discussed a lot about contraindications for continent urinary diversion.
Yeah, we need to know what her current renal function is.
Yeah, so we have to have an idea about the upper urinary tract, and the creatinine is 0.8, and we also did a DMSA scan to see whether she has a severe scarring of the upper tract, but she had not, and the most important information is she is continent. So what type of urinary diversion you would like to offer her? And I think we have these options. We could do a conduit, we could do a pouch with a continent stoma, and we could do an anal low-pressure reservoir. In this special case, we cannot perform at least a bladder, an orthotopic bladder, because it's an exstrophy case and she has no sphincter available. So we already discussed conduit. Is it wise to do a conduit, an ILL conduit in a kit with these data out? Can I have your opinion about it? I mean, you said it's not an outdated approach in adults. I absolutely agree. But in kids?
I think the problem would be that in a child that age, as shown by Charlotte's slides, after 15 years, you've got a very high complication rate. So I've followed up some pediatric patients with conduits 15, 20 years on, and they all invariably have significant complications and require significant revisions. I mean, I think this case clearly asks for a continent pouch really as the main way forward. So that would be my preference.
What do you think is the reason why they develop these complications in an ILL conduit? Is it the reflux, or is it the diversion itself?
I think it's a combination of factors, but also I think a lot of the times we use conduits in the cancer setting where 50% of the patients die at 5 years. So a lot of people don't recognise that how many, in particular the stomal complications of the prolapse, and the more and more patients I see after long-term ILL conduits, the more and more it becomes tedious having to revise that stoma. But you're right, there is upper tract dilatation progressively, but that's not always obstructive.
There was a paper in 2015 from a centre that presented the long-term data of their paediatric population, and 85% of them thought they had poor quality of life. So the kids, they do not like it. And they suggested you should almost use any other alternative to an ileal conduit, be it a ileovesicostomy or a colonic conduit that you could convert at later life.
I absolutely agree, but what if you're in a situation that you have a bad renal function and you would like to keep the renal function as long as possible? What you do in this case? Because we just learned this morning that impaired renal function is not a good idea with a continent urinary diversion, because then you will get at least a decrease.
So I think the further you go, the tougher it gets. A lot of these patients who are now adults who had ileal conduits very early in life and then were undiverted, if you present them the fact that they've got deteriorating renal function and they need something doing about it, they are so reluctant to go back to having an ileal conduit and an incontinent stoma. But I think that if you're in that situation, it's something that you have to try and confront with them, but it can be a very difficult conversation.
So what we learned in Mainz was we had a quite large series of sigmoid conduits where we could do an anti-reflexive implantation. So in a pediatric population that due to the anti-reflexive implantation, the long-term data were much better. So when we were in a situation that we were not sure what will happen with the kit, we performed a sigmoid conduit and then diverted it later on. And the big advantage is that you can use the anti-reflexive implantation, so you can incorporate that conduit easily in another type of urinary diversion. So this brings me up to the question of ureteral implantation. Is it necessary to do an anti-reflexive ureteral implantation, and in which type of diversion? Let's start with the continent pouches.
Yeah, I don't think it's that significant. I think it's very significant in ureterosig, but I don't think it's, if you've created a low pressure reservoir, then I don't think reflux is a significant issue. So I would say that I personally don't. I would sometimes put just a small little anti-reflux thing, but not a significant one, because I'm concerned about obstruction, which is more of an issue. So as far as I know, I tend not to do a refluxing.
I think that's a really interesting question, and I think there's not a clear answer. I mentioned the Hauptmann diversion and the fact that that had then subsequently had a modification for a seromuscular tunnel to create an anti-reflux mechanism, and that has been shown in the literature to be beneficial in protecting the upper tracts. But I think you will find very divided opinion on it. I don't think there is enough out there to say that one particular diversion definitely needs anti-reflux and another doesn't.
I think you lose more kidneys through obstruction than reflux. So if you can create a non-refluxing but non-obstructed system, then all well and good, but I think it's difficult.
Dan?
Yeah, I mean, I'd still work to the WHO consensus, where if you have an open system, like it's connected to the urethra, then you don't necessarily need an anti-reflux. But if you've got a closed system where you're relying on catheterization through a continent diversion, I would make an anti-reflux mechanism.
I think it's mandatory in the sigma rectum pouch, of course. That's the only really urinary diversion. For 100, for sure you need it. And I personally would do it in children. In all the others, it's a matter of discussion, and at least the literature is not conclusive. Other questions about, yeah, please. Please go to the microphone. Questions about ureteral implantation and conduits.
Hi, Jo Cresswell from Middlesbrough. I'm not a reconstructive surgeon, I'm from a hands up, but I'm interested to know with this young girl, could you look to see if she's refluxing through her existing ureters? That's the first question. And if she is, would you consider taking those ureters off the trigone and implanting them into a ureterosig? Is that a reasonable thing to do?
Yeah. Very good question. I mean, she for sure is refluxing, because if you just take the trigone and the in bladder extrophies, they all have reflux. So, but you could fill the rectum with, let's say, gastrographene, and then you will see that she is refluxing. And the reflux was the reason why she had this troubles. Yeah. Okay. Further question at this moment? So then I'd like to continue with the discussion, and an option would be a pouch with a continent stoma. The child is living in Russia, and I think this is also an important information. If a child comes from abroad, one has to be sure that she has catheter material available before you do any type of catheterizable stoma. And we also discussed problems of it, and I'd like to know from the panel, what is the reason for, let's say, stones, mucus retention in these catheterizable stomas? And you more often see it in augmentations than you really see it, at least in continent pouches. Do you have an idea?
Well, I think it is stasis. I mean, it's always difficult to completely empty the bladder completely. So I think over a repeated period of time, this is why you get the calculi and the mucus forming. And so it's an variability in view of you've got a system where you're going to have to put a catheter in, whether it's 12 or 14 French. It's not sufficient to take out all the stuff. Hence, it's not surprising that you get the stone formation.
Okay. Dan? Oh, sorry.
Well, Riz wrote this up through UCLH and found that there were two major factors. One was relating to urinary citrate and one relating to 24-hour urine volume. So if patients don't drink enough, they don't have the right kind of balanced diets, then there's a much greater preponderance towards stones. So that's extremely important. But bladder washouts and discipline with regular catheterization and complete emptying are very important too.
There's probably one other thing that I should mention for completeness, and in terms of some of the continent nearbladders and the orthotopic nearbladders, techniques change, because if you use stapled anastomoses, you often get stone formation attached to them. So I know Charlotte touched upon it about changing a stapled anastomosis, even on the end of a blind end of a conduit, to a hand sewn is important. But a lot of techniques have had to be adapted over the years because of the problems with stone formation on staples.
This is a very important point, and that was the big difference between the ileal nipple and the appendix stoma, at least also in the MIND series. As soon as you use staples or non-absorbable sutures that are in contact with urine, you will get stones. And this is something you really should avoid, especially you should avoid it in the pediatric population. And there is one thing that hasn't been mentioned, and that's how the tunnel or the continence mechanism is performed and where the tip of the catheter is reaching. So when you see some of the pediatric population, the Mitrofanov is done transversely. So the tip of the catheter will never reach the bottom of the bladder. And this is something which is also important. If you do a continence mechanism, you have to do it in a way that it enters the deepest point either of your augmented bladder or at least of your pouch, because if there still is some things in it and you cannot enter it properly, then you will get stone formation. And therefore flashing at the beginning of a continent pouch is very important to get the mucus out if they still have mucus in, and you have to show the patient to pull in the catheter, to draw it back a little bit, and then you move that you really get into all these corners. And this is especially in the pouches sometimes not so easy and needs some training, and it's important that the patient do it. And of course the fluid intake. This comes to another point. We talked about continence, and we have seen that also in the pouches with continent stoma, as also in the sigmorectum pouch, there is a principle of decreasing the pressure. So we are dealing with low pressure reservoirs. And this is something, to my opinion, is very important concerning the intracorporeal urinary diversion, because what the surgeons do to simplify the technique, they don't use the third loop, they just do a V. And therefore, you don't have a spheric reservoir, and this might be responsible for at least less continence rate in this group. Maybe you can comment on that? How important, you have shown the pictures how important it is.
Yeah, no, I agree. I think that it's hard to level criticism because there isn't really long-term data from the newer nearbladders that we're seeing through robotic surgery, but it appears that the surgeons have adapted the operation to fit the technology. And I think it's slightly worrying. We'll see over time whether or not that is borne out with continence data. But I would like to see more spherical. I think you get better volume, better pressure, but we will see with time.
Further comments? Any questions from the audience?
Are there any robotic criminals in the audience? I know we're all proper single port surgeons.
Well, I was going to just add to that while Tam's getting the microphone that actually Joe and myself, who both work in Middlesbrough, have actually discussed this this week in the run-up to this talk about the fact that in centres where intracorporeal orthotopic nearbladders are starting to be performed, it's often the cancer surgeon who has the robotic skills who is doing this, and that actually the way forward may be collaborating between reconstructive urologists and cancer oncologists to ensure that the reconstructive principles are followed and that doesn't affect the outcome in any sort of negative way.
Hi. Thanks. Great session. I've got a comment and a question. The first comment is, it's conduit, it's Old English, it's not French. And if you go into your dictionary and listen to it, it says conduit. And the second thing is, Why? Thank you.
I learnt that in 2002 on a ward round.
It was Mrs. Venn. I was a registrar in 2002. I'm lying. Why have we got such a low neobladder? Why do we do so many ileal conduits in the UK? Is that just the way it should be, or should we be looking in on ourselves and seeing how we could change?
It's a really interesting question, Tamsin, actually, and I think that's why I put up the American and European data in comparison, because we do seem, on the face of it, as if we're lagging behind in this country. But then if you dig into the data from America and Europe, it is very centre specific. So in the centres which are tertiary centres who specialise in reconstruction and orthotopic neobladder formation, then they have much higher rates. Now, you could argue that there might be several reasons for that. You know, that is their practice, that is what they're comfortable doing, that is, there may well be a degree of surgeon bias to talking the patients through that, or it may be that the patients were referred in because that was the patient choice. They said they wanted an orthotopic neobladder, and therefore they have been referred to that centre for it. And maybe, actually, the rates in Europe and America that are equivalent more to the NHS in the UK are lower and are around 10 to 15%, but that still leaves us behind in terms of only just under 7% rate.
But Mary, even with the move towards centralisation, with the change in the cancer alliances, etc., we're not seeing that increase in either neobladders or diversions, are we?
No, and I don't think I can answer why. Maybe the audience has some ideas of their own as to why that might be.
I was going to say Tamsin's doing that, which I don't think is because she's going clubbing later. Are you sure? I think there's a skew also because of the adaptation to new technology and the tendency to do a simpler form of diversion using either laparoscopic or robotic techniques.
We're now playing around with techniques, and we may get an increase in continent diversions at a later stage, you think?
Yeah, I mean, the oncologists are leading the...
Microphone, please.
Wait.
So that's not true. You can't impose on patients what they choose. You give them the options, give them the pros and cons of every procedure, and they have to choose. You can't be dictatorial.
You're absolutely correct. But if I'm to polarize it, if I'm a surgeon and I sit in front of a cancer patient, I will persuade them to have an operation because that is what I'm most familiar with. If I'm an oncologist, I'll persuade them to have radiotherapy or some form of other torture because that is what I'm most familiar with. If you're a surgeon that tends towards a particular technique, you will similarly have a bias towards that.
But I must say, at a center where we really can offer all types of urinary diversion, really the diversion type we mainly do is ileal conduit, and that has a couple of reasons. Because those cancer patients we see are getting older. We have quite a lot of, let's say, 80 plus that are in a very bad shape, so you would not do a continent urinary diversion on them. So, and I don't know why, but in females it's less often performed, and we also have some prospective multi-center data in Germany from the Prometic study group, which clearly shows that females are more seldom offered a urinary diversion than in males, because I mean, and this also has to do, I mean, we could offer it at our center, but I see at other centers, I mean, what the people are able to do is an ileal conduit and an ileal neobladder, and these are, let's say, quite simple techniques. When it comes to a pouch and the appendix is not there, and you have a complex procedure that you do once or twice a year, you're worried to do it. And these are all, I mean, it's a multifactorial reasons why these people, or why continent urinary diversions, even nowadays we have the technique established, are not performed so often. But there was a comment over there.
Coming to the robotics thing, that if a robotic surgeon is doing a reconstructive procedure, he has to duplicate what we do in open surgery. Otherwise, he shouldn't be doing that procedure.
Agreed.
Very good. There was another
can I
comment.
just comment, 'cause I've thought quite a lot about this. We've hit quite high figures in Glasgow at times, 38% one couple of years ago in our reconstruction rates, so far, far higher in quite a poor area. And one of the reasons I think is in the UK, surgeons aren't used to operating collaboratively. if you do one person has to do the cystectomy and then the reconstruction, a lot of surgeons, particularly cancer surgeons, will say, that's a lot of work. We're not used to, in the NHS, I think, in a lot of centres, in 2 surgeons doing it. It is far, far easier to have one person take the bladder out and the other person to do the reconstruction. And if we had that, if people used that model more, we would see more reconstruction. I'm absolutely sure of it.
Although I think
it is, yeah, but I think that...
it's interesting you should make that comment, because I was going to make exactly the same comment, saying that I've done both. I've done the cystectomy and the reconstruction myself, all in one go, and now I offer my services to my oncology colleagues.
I've gone through the same process.
Reconstructions, and the rate of reconstruction has not gone up. It's what the patients choose. It's what the punters want, it's what they get.
Okay, over to another Scotsman.
Yeah. I'll try my best, but I spent some time in Ireland. It can't be worse, so you can translate if possible.
You want to try Scottish or European? I just wanted to make a comment that the last big series from the UK was Derek Fawcett's series in 2008, which had 208 patients in it. It was the same year that Hauptmann published his data of over 1,000 patients in a similar time period. There can't be that much disease difference, even accepting demographics and so on. So this is a cultural difference that we're seeing between different units.
No, but this is bioselection. When I worked in Mainz, we did quite a lot of Mainz pouches, but the people from all over Germany came to get a Mainz pouch, and the same with Hauptmann. I mean, they know he is famous for ileal neobladder, and those people, they travel over there. The same we have with the Martini Clinic at my institution, performing 2,000 radical prostatectomies a year. So the people are coming from everywhere. It's not that we have a high incidence in the area of Hamburg. The patients nowadays look to the internet, and then they search for the center with the maximum of experience in it. So I like, at the end, just to ask one question about follow-up, because we heard that in urinary sigmoidostomy we have secondary malignancies, we might have some metabolic changes, so maybe each of you could just mention how you would follow a patient with your respective technique. Follow-up of continent urinary diversion with a catheterizable stoma.
I think it would be sort of 6 weeks. See them do a series of blood tests, including for bicarbonate, and then if they're well established, then it'd be a sort of six monthly, extending out to a yearly basis, because they do get complications later on, and that would be predominantly in terms of an ultrasound scan, KUB initially, and battery of blood tests, and if there's any subsequent issues, then you deal with either CT-KUB, depending on the size of the stone. That'd be the most common problems you'd have. In terms of complications of the actual stoma itself, you may need initial dilatation, potentially 3 to 6 months if they've got stenosis at the skin edge. But it's essentially lifelong.
Yeah, it's essentially lifelong. I reiterate that. It would be basically, in terms of long-term follow-up, you're looking at both the upper tract and metabolic complications. So upper tract imaging, usually ultrasound, annual ultrasound, regular clinic follow-up, either 6 monthly, yearly. It depends on the patient and where they are in that process, with a full raft of bloods to keep an eye out for your metabolic complications, and potentially cystoscopic surveillance if indicated in the long term.
It'd be nice to get anyone back to my clinic, but and obviously the bladder cancer patients have their own form of surveillance anyway. But I think you need to pick up the silent obstructive consequences. So that's an ultrasound. Your GP can watch their renal function, should check their bicarbonate, their chloride, and the patients will know when they're getting too many infections and their stomas are playing up, so they'll come and find you. But I think we can't follow everyone up forever, all of them, but if you give the patients information as to what they need to tell us about, then that should be possible with a conduit.
I think if you've done any form of major reconstruction, it's a contract between you and the patient. You need to follow them up for life. They need to have annual ultrasounds. They need to have a battery of bloods. And if you've used any part of their ileum, you must check their B12 regularly.
Okay, I'd like to thank all the speakers for
I just
Margaret?
would like to show what we did with the case. So I resected this part of the bladder, this trigone, and because the child was very happy with what it had, then we did again a sigmorectal pouch, and we used the serous-lined extramural tunnel because the ureters were dilated. This is a modification of the initial technique. And you see there, you create at least 2 funnels, and then in this, the dilated ureters are put in, and it looks at the end like that. And this was the picture pre and post-op, and I have seen the child 2 years ago. She is now almost 20, and she's very happy. Thank you.
Okay. I'd like to thank the speakers for giving us entertaining talks, for Margaret with a very good case to discuss, for the audience to getting involved and enjoying it, and for a lively discussion. So thanks very much, and for everybody keeping to time.